Good morning, everybody, and welcome to our first official day of our CRE, our Centre for Research Excellence, on pneumococcal disease control in the Asia Pacific symposium that we're having. I'm Professor Fiona Russell. I'm Director of the Child and Adolescent Health Program at the University of Melbourne, here in the Department of Paediatrics, and also is Group Leader of the Asia Pacific Research at MCRI. So I really welcome you all. I'd first like to pay my respects to the traditional owners of the land, which we're gathering today, and that's the Wurundjeri people of the Kulin Nation, and to their leaders past, present and future. And it's lovely to see so many familiar faces in the audience. We haven't had a lot of face-to-face meetings in the last 2 years, and since our CRE started last year. It's a 5-year thing, but this is our end of our second year. This is actually our first face-to-face meeting, and we've had lots of Zoom things that you'll hear about shortly, but I haven't got to say hello to all the visitors yet, but I just thank you for travelling such long distances to come and gather today to talk about or this week actually, to talk about such an important topic. So I'd first like to thank our funders, our Australian Government National Health and Medical Research Council, for funding our Centre for Research Excellence, which many of us are part of. I'd also like, for this particular forum, thank the Bill and Melinda Gates Foundation that's also provided some funding so that we're able to invite additional visitors to come and join us, and also in person, and also to thank MCRI, of course, for hosting our CRE and all the infrastructure and support involved, and also our Department of Paediatrics on campus as well, and Gus, who's providing all the IT technology to support the day. And in particular, I'd like to thank Claire and Darren, who's really done all the work, and many of you would know and been involved with, particularly, yes. So Claire is our program manager, really, for our CRE, and Darren is our organiser, essentially, and research manager for our group, but also for the CRE. And so really like to thank him for all his amazing effort, because it's been a huge amount of challenge to get everyone here. And I'd also like to say that thankfully, everybody who wanted to come in person got a visa. And so we didn't have any issues with visas coming to Australia. So I'm really thankful for that as well. So we've got a great lineup today. The focus really is on our next generation. So really investing in our next generation is the best thing that we can do for anything, really. And so our early career researchers, we're going to hear from them today, and also hear about what else we can do to support them, and also regional capacity as well in making, using data for decision making. And also in particular is encouraging women in the sciences and in leadership, and we're going to hear from somebody later on this morning about that. So, and then we've got an early career session later on, a work in progress, a lot of young career, some supported through the CRE and others not, but hear from them about their work in progress and what they're up to. And then we've got a really interesting panel session this afternoon on health economics, and not just PCV, but really all the other vaccines and what countries need in terms of making decisions and how they make decisions, and in particular in the context of COVID. Catherine Satsky's group got a microbiology workshop, so has a lab tour. And then I think Darren and the early leadership group has organised a session for our early career leaders to have a networking session over, I think you're going to the pub or somewhere, or a cafe, to have a chat. And so that's really nice. And then yesterday, and tomorrow, then we get into more about policy decisions, sort of more high level, what data, health economic, epidemiology, modelling, etc. And then the vaccines and surveillance, and some of the details on some of this data that's needed for decision making. So I'm going to hand over to Claire now, Dr. Claire von Mollendorf, but it's really lovely to see you all, and thank you for participating. We've got, I don't know how many we've got online at the moment. Still trickling in, yep. So we've had about 160 registered, is that right? 250 people registered, that's great, but not everyone turns up, but yeah, and then also 60 in person, I think. So hopefully people will come in and out of the session as well. But really, I hope you enjoy the next 3 days and have lots of chats and lots of times to network. And it's really wonderful that we're all here together to talk about such an important topic. So I'll hand over to Claire.
I'm just going to jump slides. That's acknowledgement. So maybe just to mention, so as Fiona said, the Centre of Research Excellence for Pneumococcal Disease Control in the Asia Pacific is a grant that's funded by the Australian government. And essentially, we aim to look at research gaps, especially as with regards to pneumococcal conjugate vaccine use in the Asia Pacific region. And as most of you know, PCV is one of the main vaccines that we can use to prevent pneumonia, which is the main cause of childhood deaths globally. And the CRE is really a collaboration of a number of people who are actually sitting in the audience today across a number of countries. And just to mention in terms of chief investigators, so there's Fiona, Paul Licciardi, Catherine Satsky, Kim Mulholland, Mark Jitt from London School, Sarath Ranganatham, Peter McIntyre, Kacham Nguyen, Yin Bun, who's sitting in the audience as well, and Natalie Carvalho. And in terms of our associate investigators, many who are here as well, so there's Chuan Nguyen, Kulkanya, who unfortunately couldn't be here, Anna Ong Lim. I've only got Steve Bentley, Mei Fong, who I think is also online, unfortunately, Eric Rafai, who couldn't be here, but I think Rachel is joining us from Fiji, and then Toya Mungun, who's from Mongolia. So it really is a collaborative effort, and we couldn't do anything without our partners in the region. And I think what's really prompted us to do this annual symposium as well is, as everybody knows, in the last 2 years, the COVID pandemic has really impacted negatively on vaccines. So a lot of children have not got their vaccines in a timely way. It's really impacted programs. Programs are now, governments are now relooking at their vaccine programs and trying to see how they can save costs, how they can catch up and try and catch all those children who didn't have their vaccines during COVID. And there have actually been a lot of outbreaks of vaccine preventable diseases in a lot of countries. So I think the symposium is really timely. So in terms of the symposium, the main aims are to look at access and sustainability of the pneumococcal conjugate vaccine in the Asia Pacific region, to look at key research needs, and to also look, as Fiona mentioned, how to support the development of research capacity in the region. So we've got a large group of early career researchers. Sorry, I haven't mentioned all of you by name, but who we really want to make sure they're the next generation of researchers. And we really want to make sure that whatever happens in this program, it's sustainable and feeds into the next generation. And just lastly, Fiona already mentioned the program, so I'm really excited about today. We've got a focus on global health and STEM, and especially in the context of women in STEM, which I'm a bit biased, but I feel that's really important. A really exciting session from our early career researchers, a health economics seminar this afternoon, which will also be in the Ella Latham as well. And then some exciting plenary sessions tomorrow where we'll hear from DFAT and WHO, looking at reducing schedules. So governments are trying to cut back costs. So is there a good way that we can reduce schedules and still make sure that children are protected against vaccine preventable diseases? A session looking at health economic data, immunology data tomorrow. And then day 3, we'll be looking at carriage, genomics, and also looking at vaccines in special populations, for example, in malnourished children. So really packed program. And then there's a housekeeping slide from Darren.
Hi, everyone. Just a little bit of housekeeping. So thanks, Claire and Fiona, for giving a really nice overview of the things that will be happening for the next 3 days. This is in particular for people who are attending in person. So all of you in the audience here in Ella Latham, we've just been advised by the Royal Children's Hospital that we are now required to wear a mask in all areas of the hospital. So unless you're eating or drinking, we do request that you please wear a mask throughout the next 3 days. Please keep your phone on silent. And toilets, morning tea, as well as lunch can be accessed through the rear entrance. So I'll be sitting right up the back. So if you need some directions, just let me know. You can also access the event program using the following QR code. But if you need a printed copy, you can also let me know and I'll have some on hand. For external attendees, so all of you who are not MCRI or RCH staff and students, please do sign in at MCRI reception each day. But again, MCRI reception has requested for you to sign in through RCH reception instead. So if you could just make your way through each day into RCH to do all the screening and then make your way into Ella Latham, that would be really helpful. Thanks very much. I'll hand it back to Claire.
Okay, great. Okay, so we're going to kick off with our first speaker. So it gives me great pleasure to invite Professor Jaria at Tabari to come and speak to us on how academic institutions here in Australia can support the region in improving and developing global health capacity. So Professor Tabari works in the Department of Pharmacology and Therapy and the Clinical Epidemiology and Biostatistic Units at the Universitas Gadjah Mada, Indonesia. Professor Itob is a member of the Indonesian NITAG and has extensive experience in clinical trials and vaccine introduction. So over to you. Thank you, Professor Itob.
Good morning, everyone, and very happy to be back here after 3 years not traveling to Australia. First of all, thank you for Professor Fiona for the invitation, and then this is a very great event that I could share our experience working together with the Australia government and also the institution like Melbourne University and MCRI. This is what I would like to share to all of you related to our work from rotavirus vaccine development between Indonesia and Australia. So this is related to the global health capacity collaboration that we started already almost 12 years a year ago. This is the situation now in Southeast Asia countries, especially in Indonesia. So the mortality rate of the children under age of 5 still high compared to other countries. Southeast Asia countries, especially in 2020, still not reach the sustainable goal to have the lower mortality rate in children under 5. In Indonesia is similar. Our data show mortality rate still reach 23.9 per 1,000 live births in 2020. And when we look at again, not under 5, but this is infant mortality and maybe a little bit better, but still high compared to other countries in the region. Indonesia is one of the high mortality rate in ASEAN countries. And our target is to decrease the infant mortality to 12 deaths per 1,000 live births in 2030. So this is really a big ambition, I think, from government to reduce this mortality. The cause of the infant death are now also getting more complicated because a lot of these related as well with maternal health, during the pregnancy, and then also the first months of the postnatal care. This very critical issue because most of the infant mortality also in this age. So the government make already the projection for infant mortality in Indonesia 2030 that I mentioned earlier, to reduce the mortality to the 12 per 1,000 live birth. And of course, this is need the infant intervention scenario. If we doing our business as usual, what we have done currently, and then we do not have a very strong intervention, so our mortality rate is not reached to 12, it's only to 15.6 mortality per 1,000 live births. This is the scenario that we face at this moment. So when we look at again how actually we could address this, our issue in Indonesia, and then we back again to our burden disease under 5 children in Indonesia. So you see here, there are 2 diseases that's very almost 40% cause the mortality. One is diarrhea, especially rotavirus, and then the second is pneumonia. So I think this is very good event because this is what we also going to discuss. This is a gap of the utilize of the vaccine in the region. And then as you know, these 2 diseases actually preventive, vaccine preventive disease. And other common mortality cause also measles. Our immunization program tried to reach the high coverage in Indonesia, and then dengue is still very high, and also meningitis and encephalitis. In terms of the rotavirus, you see our Indonesian rotavirus surveillance network show 45 to 60% under 5 children diarrhea are positive with rotavirus, especially for the acute diarrhea within the hospitalization. And diarrhea, according to Ministry of Health 2019, cause of the death 12% and are below 1 year, and 10% between 1 to 4 years. And then pneumonia, you see the data over there. They are increasing of the number of mortality and also the incidence of the hospitalization according to the age specific. So what we do the intervention, actually, we are going to strengthening our vaccination program. Pneumococcal vaccine PCV has been started in 2017 in the demonstration project in Nusa Tenggara, West Nusa Tenggara, Lombok Island, Sumba Island, etc. And then Javanese encephalitis, also one of the biggest cause mortality, been introduced also 2017. Rubella and also measles, rubella, introduced also 2017. But at this moment, this PCV, Javanese encephalitis, and then MR are still in the demonstration project. And then also rotavirus vaccine will start it this year. So we hope this year pneumococcal vaccine will reach our nationwide. This is the plan. Javanese encephalitis as well, and rotavirus will be gradually implemented in Indonesia, and then nationwide will be reached in 2024. And the coming vaccine that we also looking forward for introduce is dengue vaccine, typhoid vaccine. And then I would like to look at more deeply about what we have done in terms of the planning of the rotavirus vaccine. So rotavirus vaccine in Indonesia is been developed together with MCRI and then also Bio Farma, a state-owned company in Indonesia. This collaboration is took already almost 30 years by our senior, starting when the rotavirus discovered by Professor Bishop. And then it's been collaborate on that time between Australia, Indonesia, to find whether the cause of acute diarrhea in Indonesia at that time similar what they found here in Australia. And then since then, develop a lot of infrastructure and develop of the guidelines, guidance to treat and to manage the child with acute diarrhea. MSRI developed new vaccine starting in 2006 for the clinical trial, instead 2010. And then Indonesia also starting for doing ASEAN rotavirus surveillance network and Indonesian surveillance network, also together with a colleague from MSRI. Under development of this vaccine, after phase 2A, RV3BB in New Zealand, and then starting this clinical trial in Indonesia, I was involved in this study since 2010. Preparing all these infrastructure resources to conduct the clinical trial phase 2B in Yogyakarta and Central Java. After the study done, phase 2B, that show the vaccine are very safe and then very high efficacy, even in the low income countries such as Indonesia. MSRI transferred the technology to the biopharma manufacturer. And now biopharma manufacturing for the clinical trial. And we started phase 1 study in Indonesia. And now we continue to phase 3 study. The study will be completed next year. And hopefully we can implement this vaccine to Indonesia setting. The other collaboration that we make together with the MSRI is not only developing this vaccine, but also to provide some evidence for the decision making. We develop a cost effectiveness study together for rotavirus, and then the budget impact analysis for the government to implement the rota vaccine. And now we also preparing for the study to continue to look at the impact and the effectiveness of this vaccine when they implement next year. So this is a very long collaboration. It took many years between our institution with the University of Melbourne and MSRI. And then from generation to generation, when I was started this project together, I'm still very young, even though I'm still young now. I started my career actually is from this collaboration. So now this collaboration will continue for the next generation, also from MSRI and also from Indonesia. So the many publication, international publication been released. This is only a few publication that we had. Maybe there is dozens of the publication resulted from this our collaboration. This is one of the very great achievement from both sides. So when I learned it after 12 years collaboration, this is what I learned from this collaboration. The capacity building that developed between Indonesia and Australia. The first is on vaccinology. We learned a lot about the vaccine, how the implementation, how to do clinical trial, how to manage the trial, especially in a low resource setting. We also have capacity to build our lab, especially for detection for rotavirus, genotyping, etc. We developed a robust surveillance system in Indonesia for rotavirus. We manage all data together, because this data management is quite difficult to set up the quality of the data. And of course, for local vaccine manufacturer that have the transfer technology for developing this vaccine, publication, international publication, and other things that we learn is how to access the global funding, because Australia and Melbourne University has a big collaboration with the very high global funding. And of course, that's what I learned a lot about as a young scientist, how to develop the capacity to do research, PhD, and also some specialists in infectious disease. So Data, what I would like to share to you, what the support from the academic institution in high income country to low middle income country in the region for the global health. The first is to develop the equal partnership between this region. The second is when the global health funding awarded to high income countries institutions, make sure that involve also low middle income countries. I think this is what aimed by the high institution in Australia. Include the low middle income countries research capacity building element, especially for the training of the young scientists and researchers. The second is about a study on epidemiologic study, the qualitative study, health system work to understand the local burden of disease, the healthcare beliefs, and then other local contexts. And also during this collaboration, make sure this collaboration also reflect the local needs. I think that you mentioned that Professor Fiona mentioned these 2 days, we will look at all the data needs for the implementation of vaccine in the region. I think this is one of the important session. And the other is plans to also hand over all the infrastructure, especially when I learned about the Rota vaccine, how the technology been transferred in our country. And they have to be in realistics and then also predetermined time frame. So in terms of the research capacity in the global health, there are 3 things that I consider. First, the training and the career development, especially supporting the career young scientists in the region, because they will continue the collaboration, of course, and also the one that will in the future researcher. Doing the training researchers and also the training the scientific administration, and of course for the colleague from high income countries is also have the experience how to conduct a study or research in low resource settings. In terms of institution, I would like also to suggest that to support the master degree and PhD degree in the low income countries, especially to develop the curricula on research methodology, on the vaccine research, etc. And the other is also the support cross-cutting research. A lot of informatics technology, the bioethics issue on the research should be also addressed. And this is sometimes it's not really focused on the research. The other is about research funding, collaborative research, and then also how to get the funding. So of course, there are some responsibility for the academic institution in the high income country and also low medical income countries. The first for high income country is develop the proposal with the equal partnerships, and all researchers involved especially contribute to manuscript. Yeah, this is very important for us in the low middle income country to able to have capacity to contribute and writing for international manuscript. Provide in-person training, whether this is in the countries, high-income countries or in the low-income countries, and continue with the online program for mentoring and the training. And of course, the institutionalizing relationship between the institution, this the important to recognize this collaboration. For scientists in the low-income countries, this is what I learned as well when they implement the vaccine, rotavaccine in Indonesia. We need to work together, tightening with the local governance, with the local governments as well. Improve our leadership and accountability for all level. Sometimes the transparency is very important, and then also the hierarchy institutional in low middle countries sometimes are very difficult. The other is involve discussion in all relevant research proposal to make sure this is related to local context and then local priorities. Make sure the data quality and then in the infrastructure to able to have adequate training, funding, and of course the time to conduct this research, and then invest in online and other non-traditional income for resource funding. So this is what the issue, the global health collaboration, especially for infectious disease, that we can collaborate between the Australia institution with other institution in the region. First, to look at the collaborate, to share the data, and then to look at all together on the disease burden, because this collaboration necessary because sometimes we have a similar issue, similar obstacles on the vaccine implementation. So this may be for us could be shared the data together. And then the also related to intervention strategy such as vaccine, vector control, disease modeling, and health economics. I think this has been addressed quite well by the SPARC and Spectrum. And then program implementation, including to look at the effectiveness of the vaccine, impact of the vaccine intervention, and how we can strengthening the health system, and then also to find the innovative funding scheme. I work together with colleagues from Singapore to find the innovative funding scheme for our immunization program in Southeast Asia countries. This model and then the paper is being published, but we're going to start the innovative funding actually 2020, but unfortunately we have a pandemic and then the funding is being stopped. So I think that's good to continue to look at because a lot of countries in the region need other scheme for funding for the immunization. So this is, I would like to also propose the initiative to have a vaccinology network in the region, in the Asia Pacific. So network capacity for the vaccinology is also to give training on the vaccinology and immunology. We learned a lot during the pandemic. Anybody could speak about the vaccine, but little people actually understood really about the vaccine. So I think regulatory clinician researcher need to have comprehensive training on the vaccinology before they could understand the whole process. And the other network probably is clinical trial vaccine development. Yeah, I really appreciate there are study collaboration between these Southeast Asia countries on pneumococcal vaccine, especially to have 1+1 scheme of the vaccine for PCV. And then also strengthening the health system in the countries, and also collaborate on the vaccine vigilance. Yeah, we during the pandemic we have vaccinate in Indonesian population. Now the data today is almost 210 million people. This is a really huge population. But when I look at the data of vaccine vigilance, we hardly have data. So I think this is really important to strengthening the vaccine vigilance. We have our consortium, and then also in Indonesia, how to monitor the safety. But we hope this is also could be shared and then could be work together. And the other is vaccine economics, and then also related to the modeling of disease transmission, so that we can together prepare the emergency in the future. And of course, that could put innovative funding for the immunization. So this is to conclude the collaboration that between Australia and the region hopefully could able to something that very important for the region, with the equitable partnership, with the innovative project and collaboration, with a good communication, and then also commitment between the institutions, and then continues together to achieve the goal of the global health. I think that's what I learned from almost 12 years work together with MSRI, continuously work together, and then with the same goal, and then we could reach a better life for our children. Thank you very much. And then thank you for our collaborators from Gajah Mada University, Murdoch Children Research Institute, University of Melbourne, Biopharma, Ministry of Health, PATH, and London School Hygiene and Tropical Medicine. This is what our collaborator. Thank you very much. Hope that I could share. This is the one that I could share for you all. Thank you.
So thank you, Professor Artab, and thank you for sticking to time. We really appreciate it. The Q&A will be at the end of the session, so please make note of your questions. And also for people online, we are monitoring the forum on an ongoing basis, so please post your questions in the Q&A or chat. So online, we have Dr. Senjuti Saha, and I'm really excited about this presentation. She's speaking about a topic that's very close to my heart. So Dr. Saha is a microbiologist at the Child Health Research Foundation in Bangladesh, and she focuses on pediatric infectious diseases. Her work aims to improve laboratory testing methods in low and middle income countries and understand the indirect impact of health interventions such as vaccination on the overall health systems. Her work is strongly grounded in advancing the cause of health and research equity. So Dr. Saha, her topic is growing capacity of women in STEM. So I'll hand over to you, and are you happy to control your slides?
Thank you so much for inviting me here today. I'm super excited. I am going to talk about women in STEM and some of the work that we have been doing towards increasing participation of women in STEM in the context of Bangladesh. But before that, I kind of wanted to tell a story of how we have been gradually building capacity with using an example of genomics and the lessons we have learned from trying to build genomics capacity, and what made us realize that it's really, really important that we have local leaders and we have local women leaders. So I often start my talks with this slide over here. So this is a slide that basically shows in red dots where most of the children die across this world. Every red dot is equivalent to 10,000 deaths. It's a little old, but the data is still very similar. And what we see is that most of the deaths occur in the global south. Now, if we look at where most of the technologies lie, most of the health interventions lie, they are shown over in green, and we see they are mostly in the global north. And there is this gap, which in public health we call the 10-90 gap. 10% of the resources exist where 90% of the children die, and 90% of the resources exist where 10% of the children die. And this really, looking at this data, made us ask ourselves, how do we close this gap? And specifically, I'm a Bangladeshi, I work in Bangladesh, and my team's question is, how do we close this gap in Bangladesh? So this right over is Bangladesh, and it is the most awesome country ever. If you haven't visited, you must visit. It's the most awesome country because it has done extremely well in health. It's a pro-vaccine country. Across the country, vaccine coverage is more than 90%. In most places, it's actually more than 95%. Also, it is a country that has achieved all 3 health-related Millennium Development Goals way ahead of time, and we have received multiple awards for that, hence the most awesome country. We have the privilege of working in this country as a small nonprofit organization called the Child Health Research Foundation. Here, our mission is to prevent infections, save lives, and hopefully with data and advocacy. So we generate data through our hospital and lab networks and try to translate that such that our policymakers can understand that and take evidence-based decisions. We also want to build the next generation of scientists in Bangladesh. Our vision is to see 0 deaths and disabilities in children due to preventable diseases, and also build what I'll talk about is young leaders, local leaders who can bring about positive changes in our communities. So we have been working in Bangladesh for more than 30 years now, and we primarily focus on fever investigation. If we detect bacteria, then we look at antimicrobial resistance patterns, etc. We are located in a place or a region in the world that's very prone to outbreaks. Dengue, chikungunya, and we primarily work with hospitals across the country. So we often have to switch gears to deal with the outbreak that's happening at the hospitals or the regions within the country we're working in. I personally mostly focus on neurological and respiratory infections, not only infections like pneumococcal or meningococcal infections where we know the pathogen, but also in infections that remain mysterious or idiopathic. With all of that, we try to work with the policymakers and facilitate evidence-based decisions. In 2009, we worked to introduce a hip vaccine in our EPI program, and in 2015, the pneumococcal vaccine into the EPI program. And the biggest advocate or our guide for all the advocacy is Professor Shomi Shah in Bangladesh. So we have been doing this, as I said, for 30 years, but it was really in 2016 that we started conversations on building genomics capacity in the country. I studied in Canada. I lived in Canada for 11 years. During my PhD, I was the first one in that lab to start sequencing, and I quickly realized how important genomics is going to become in the future. So when I came back to Bangladesh in 2016, we started having these conversations of how do we build genomics capacity in the country? What exists, what doesn't, what are the models we should try? So in the last 6 or 7 years, we have been through many trial and error models of building genomics capacity, many failures, some successes, but a lot of lessons. And I think we're doing better. And the ratio of failure to success is also getting better. So I'm going to first talk about 4 models. I'm going to start with model number 1. So when we first started working on genomics or incorporating genomics into our regular clinical and lab surveillance, we did not have the capacity to do sequencing or whole genome sequencing within the country. So the first model we tried is, okay, we continue the surveillance in country, but perhaps we can ship samples to a collaborator in the global north. Remember those green countries with a lot of resources? So for some of these models, I'm going to use this pathogen, Salmonella typhi, as an example. Salmonella typhi is the cause of typhoid fever, the most common cause of fever in children under the age of 2 months in Bangladesh. It's 75% of all culture positive cases. Our group was the first to detect the first ceftriaxone resistant isolate, not only in Bangladesh, but in the entire world. It was in 2001. When we realized we should sequence that strain, it was, in our biobank, we shared the strain with one of our collaborators in the UK. And, that was our first collaboration. And it was the beginning of an amazing, amazing friendship. Sharing that strain meant it was sequenced by a grad student in the lab in the UK. And we published a paper, and you can see we are authors in this paper, including the corresponding author was from our team. So this was a very good experience, and we were able to share the data with the entire world and build relationship. So, building relationship, we think, was a very good pro of this model. But drawback was there was really no knowledge transfer. There was a strain transfer, but there was absolutely no knowledge transfer in this specific case where we didn't learn much of the bioinformatics. We would not be able to take this forward. That brings me to model 2. Ship samples to a collaborator and at the same time train a local scientist. So ship samples, ship scientists. So over here is Arif Tonmoy, sitting right over here. He did a sandwich PhD between CHRF, our organization, and Erasmus MC. This is his picture that he took, sitting with his friends right in front of Carrefour, showing that he was really in Europe. And what we did for his PhD project is we shipped about 600 isolates of Salmonella typhi to France. They were all sequenced there. And Tonmoy received all the training required for the bioinformatics to be able to analyze this large number of genomes. And it's been a really productive experience. Tonmoy not only published the first paper with such a large number of genomes from one single country, showing historical changes in Salmonella typhi in Bangladesh. He has now published many papers, but most importantly, Tonmoy has come back to Bangladesh. He learned all of these bioinformatics, and now he is sharing all of this knowledge, imparting this knowledge with the next generation of scientists within CHRF. So pro here was knowledge transfer and sustainability of bioinformatics capacity. But a drawback we realized is we lost ownership of the data. Whenever samples are shipped out of a country, conversations about ownership can get really, really awkward. And we realized perhaps that was not the most sustainable mode of collaboration. Again, we are friends with all our collaborators and everywhere we're learning, but we want, to find that model that is sustainable. So model number 3 was shipping samples to a commercial entity. In Asia now, there are many companies who sequence, and they're not super expensive. They exist in Singapore, in China. I think we shipped samples, for this example, to Novogene in Singapore. And what we did here is a super exciting work. So just like ceftriaxone, our team was also the first to record or to detect and report azithromycin resistant Salmonella typhi strains. They have never been confirmed or reported previously in the literature, and also nothing was known about what really causes azithromycin resistance in Salmonella typhi. So For this project, what we did is we took those first 12 resistant strains and shipped them to a commercial entity. And now that we had bioinformatics capacity within the team, Tonmoy and others joined, we were able to do all the analysis ourselves. And doing that analysis basically made us discover that there's one single point mutation in a gene that is leading to azithromycin resistance in Salmonella typhi. And this has, this discovery or this molecular basis has now been incorporated in all AMR detection platforms. We have now designed PCRs, cheap conventional PCRs for anyone to be able to detect the mutation, etc. So this was, again, a very good experience, right? We shipped the samples, we had our own independence, freedom, ownership, and we were able to analyze the samples too. So independence, I think, was the biggest pro, but there are drawbacks in this model also, right? There are delays. At the end of the day, we're relying on a party that's not us. They will sequence whenever they feel like. Costs depend on the number of samples we're sending. And shipment rules keep on changing in the country. But more importantly, what happens during a pandemic? When there are no flights, you cannot ship samples to a different country. That brings me to model number 4, which is sequence locally, analyze locally. So this is the first sequencer we got in 2018. It's an ISIC 100. A lot of you might be acquainted with this machine. It's also called a global sequencer, a very low throughput machine, but it's called a global sequencer because it requires very low maintenance. It doesn't require regular calibration. We can sequence about 4 bacteria at a time, or maybe 24 virus, 24, 30 viral samples. But for us, this machine was very important because it showed that we are able to sequence, right? Because using this machine, we could roll out a training program within our facility, within our organization, and empower, educate, and engage young scientists at the front lines of public health. And when young people have access to technology that they have barely read in textbooks, incredible things happen. And this is perhaps shown in what we have been able to do within 2 years of receiving that machine. I said it's a very small machine, very small capacity. But when you know what to sequence, why to sequence, how that is going to relate to public health, it can go a long way. So within less than 2 years, the first sample we sequenced is Streptococcus pneumoniae. I've already mentioned we work with Professor Shomi Shaha, and if you know him, Streptococcus pneumoniae is his favorite pathogen. So, we did that. We pleased our boss by sequencing Streptococcus pneumoniae. We sequenced dengue during the dengue outbreak. We sequenced RSV samples. Very little is known about RSV burden in the country or understood about the strains that are circulating. We also did metagenomics, and we were the first one in the country to sequence SARS-CoV-2. Till now, we have sequenced about 2,000 samples of SARS-CoV-2, and we are also hosting the next strain built for SARS-CoV-2 for Bangladesh so that we can help the entire country with the bioinformatics. In 2020, with some of the work that we have been able to show that we can do in Bangladesh locally, we were able to convince our donors that, we are ready to graduate. So in 2022, from an ISIC 100, we graduated to this pretty machine over here. It's called a NextSeq 2000. Now, instead of doing 4 bacterial isolates at a time, we could do anywhere between 200 to 400 isolates at a time. So this was a big move for us, right? We went from very low throughput to mid throughput. This was funded by the Bill and Melinda Gates Foundation. And I should definitely mention that, for ISIC 100, and even now, we receive a lot of training and technical support from San Francisco, and that's supported by Chan Zuckerberg BioHub and Chan Zuckerberg Initiative. So what are we doing at the moment, with this setup that we have? We have a full setup for genomics now. This is only part of our lab. So what have we been up to? We are piloting this model called, building a CHRF infection observatory. And over here, what we try we are trying to pilot is how do we link genome sequencing in real time to our clinical and lab surveillance. Can we sequence bacteria in real time and perhaps detect hospital outbreaks and ICU outbreaks? Can we sequence viral samples in real time? Yes, we can. We've done that for SARS-CoV-2 and also finding the causes of this mysterious infection that we see within our hospital, because in many LMICs, most infections still remain microbiologically undiagnosed. So how do we build this atlas of pathogens that are circulating within our country? With this setup, we have sequenced more than 500 Salmonella paratyphi A. Paratyphi is a cousin of typhi. Now that we have worked with typhi, wanted to move to its cousin. We built the first genotyping tool for paratyphi called Paratype. It just got accepted. We have, as I said, sequenced more than 2,000 SARS-CoV-2. We also sequenced more than 600 Klebsiella species complex, and now we are working with the Gates Foundation, LSHTM, to contribute to vaccine design. And I think I must mention also here, with being part of GPS2 with Stephen Bentley, we're also sequencing hundreds of Streptococcus pneumoniae. And the idea is this is our time to build our expertise on Streptococcus pneumoniae. We introduced the pneumococcal vaccine in 2015, as I said before. So model 4, again, gave us independence, definitely. However, it is expensive to sustain, right? It's the fundings that we receive. We also heard in the first speaker that it can be very expensive to sustain this capacity. Where will the funding come from? These are things that we worry about constantly. Fundings are now sometimes 18 months, maybe 2 years. What happens after that? I think the biggest fear of a microbiologist, at least for me, running a lab is always having a machine that is not used. And the other fear that I have, and actually keeps me up at night, is, are we replicating the colonial model? Are we again becoming too centralized, where there are a few places, perhaps in the capital city of Bangladesh, Dhaka, where we are located, some of the other groups who are doing sequencing are located, but the rest of the country is dependent on this one central location. And that is very worrisome. And that brings me to model 5, where we say sequence locally and share capacity. In other words, decentralize, in my words, become redundant. But when we started thinking of model 5, late last year, early this year, we realized that this is actually a really, really complicated model. And there is no way we should only be focusing on genomics capacity. That might be, my team's expertise, but that's definitely not the most important thing that the country needs. There has to be a lot of work done downstream before we even get to sharing genomics capacity. So we wanted to move beyond the laboratory, right? But where, sorry. But where do we start? We did a lot of research to understand where were the gaps in building capacity. We realized from data that there was a declining interest in STEM reflected by enrollments in STEM programs in universities. We did a lot of focus groups. We went to different parts of Bangladesh, spoke to mothers, families, because we also saw data that there was not only an overall decline in interest in STEM, there's actually a declining in enrollment rate of women in STEM programs, right? So the ratio of women to men are decreasing in a lot of these STEM programs, especially like math and physics. And that to us was very worrying, is very worrying. And we thought that when we think of our next model, we have to go broader. We really have to ensure that it's sustainable. And we work with people and women specifically who are younger, not only experts who are not only university graduates who already come into our lab, because that's a very small proportion of community. So earlier this year, taking all of these lessons that we learned, we built or launched a program called Building the Next Generation of Scientists. In Bangladesh, we call it Building Scientists for Bangladesh, but it's growing. We're now, seeing a lot of scientists interested from other countries too. And our objective is really to provide exposure to research culture, to provide a facility for interested young individuals to come and work, provide some hands-on skills and exposure to scientists. Because when we did all of these focus groups, especially with mothers and their daughters, I think the first thing we realized is usually they don't meet scientists. You go into a hospital, you see doctors, you see a plane flying, there's a pilot, you live in a building, there was an engineer who built it, architects, but nobody knows what scientists do because they haven't seen scientists. We are not great communicators. We are usually not in the society, I guess, talking to people. So we thought that is something we need to change, right? We need to be more open and ensure that there's interaction with scientists. So Building Scientists for Bangladesh has 3 streams. These are the 3 streams: bringing science to people. The second stream is bringing people to science. And the third stream is developing skills. I'll talk about stream 1 and 2 first. And these 1 and 2 are mainly for young girls. And not only young girls, and by young girls, I mean school-going girls. We realized that it was between grade 7 and 12 when the family, usually the mother and the daughter, are deciding what the daughter will study in university. So our first 2 streams are basically just focused on girls who are in grade 7 to 12. What do we do in bringing science to people for school students? What we do is we build science camps. We go to the most underserved areas of Bangladesh, so always outside Dhaka city. We stay there for 2 to 3 days. We take a microscope with us. We take some petri dishes with us. We asked the girls to bring yogurt, and they look, they see the colorful world of microbiology. They look at the bacteria in their yogurt. They give, their handprints on petri dishes the first day before washing hand, after washing hand. The second day they come and try to see what washing hand actually does to the amount of bacteria they have on their hands. So it's really fun. And of course, I hope our students who join the camp, but even for us, it's been a constant learning process. And the entire idea is to show that science is fun. It's not about a lot of memorization, but it's about asking critical questions. And, you need science, you need critical thinking, whether you study science or not. We also do not only science camps, usually we pair that with a dialogue, and we call this dialogue Ask Scientist a Question, where all students from that school, teachers, parents can all come, we spend a couple of hours together, and they can ask whatever question they ask, whatever question they want to a scientist, that we go there as a team, and we have to answer them. We try our best to answer them, and that again has been an incredible experience. It really shows how much appetite for learning there is in our local communities, and shows us the gap between appetite and access to scientists and research culture. Stream 2 is bringing people to science. So, in the first one, we were going to schools. In the second stream, we invite either the same communities where we are going or other communities across the country to come to a research center. Sometimes it can be for a day, sometimes for 2 weeks. It's kind of community driven. So we go to the villages, we talk to the mothers get together, they decide the schedule of the girls, because if we just invite the girls, it's probably not going to happen. And the mothers elect one mother as a chaperone. So the mother will come with 5 girls in each batch and spend some time with us, and they're coming from all parts of Bangladesh. And we have, again, we are learning a lot. They get to shadow scientists that sometimes from their own community, from their own village or town, etc. But what we have realized that as we are expanding the program more and more, it is not only young girls from the most underserved areas who are interested, but even within Dhaka city, students who go to the best, most expensive private schools are also interested. So, and I wanted to highlight this too, that there is an interest across the board because there is a lack of access. So this is Joel Torongo from an English medium school who came and completed a 2-week internship at CHRF. By the end, she was working with, diagnostic laboratory scientists and learning how to provide reports for patients. Sania is actually someone who traveled all the way from New Jersey to Bangladesh to do a 1-week internship and basically learn how to labs and hospitals work in this country. And what was really amazing is Sania on her last day accompanied me to go to a science camp that we did in a village. And she met other young girls in Bangladesh who are as interested in science as she is, like Sabiha. And this is, as I said, is an ongoing program. And you can see her, Fabriha, how she is, looking at DNA that we just extracted from a banana. Stream 3 is different. In Stream 3, we are basically focusing on students who have already decided that they want to study science. So this is catered towards undergrads, catered toward grad students and professionals. And what we do over here is we provide specialized training on next generation sequencing, microbiology, and biochemistry. And again, the idea over here is to empower, educate, and engage local scientists to create a model for capacity building. Sorry, I'm going to take a break and cough. Okay, so I hope you can hear me again. Sorry about that. In this stream, the idea is, we work with the students or young professionals who have already decided to study science in university, but most our public-private universities do not have very good infrastructure, very good capacity to actually provide with hands-on training programs. So what we did is we built agreements with multiple private and public universities. And a 4th-year undergrad can come and spend 2 to 3 weeks with us and learn microbiology, learn hands-on microbiology, hands-on molecular biology. And if they perform well, they're still interested, they can then enroll into our next generation genomic sequencing program. And that's a 3-week program where they, pick their pathogen of interest, learn how to prep libraries, load a sequencer, see the data come out, how does it come out, and how do you actually analyze that data. And we're still using, interface or softwares that are available to analyze the data easily. Not only are we providing these hands-on training programs with the support of Fine Diagnostics from Geneva, Switzerland, we're also piloting a model to see if we can build other training labs across the country. Because again, if everything's happening in the capital city, it really centralizes a lot of this training and probably not sustainable. And especially for us, we are a nonprofit foundation, right? We are not an academic institute. Our impact will never be as big as a university's impact. So can we establish or help establish a lab in a public university, let's say? So in order to do that, we basically supported a genomics training lab, building up a genomics training lab in Chittagong University. So this is Dhaka. I already showed you where Bangladesh is in the world. Within Bangladesh, this is Dhaka. And this is Chittagong, and this is pretty much where Chittagong University is. It's one of the largest public universities, and we opened a genomics lab in their genetic engineering and biotechnology department. This is us inaugurating the lab. This is the vice chancellor of the university. This is my lab manager, and Arif Donmoy, who you had seen before, also in Europe. And this is what the lab looked like in March 2022. This is what the lab looked like in May 2022. They are basically starting exactly the way we started, with a small ISIC 100. Right, it's a very small setup, low throughput setup, but enough for the professors there, the trainers, and then the students to learn how to prep libraries, what format the data comes out, and to do simple bioinformatics. And just a couple of weeks ago, we did a first run there. First SARS-CoV-2 run, and the data are on GISAID now, so super exciting. And as we, continue this and this, of course, there will probably be a model 6, model 7, model 8, I don't know, but we are constantly learning. And we are constantly thinking, what are potential models of capacity building? What have people done? What are people talking about? And how, does it differ between global, local, between individuals or institutions, etc.? So a model that often spoken about or discussed is the hub and spoke model, right? Where there's a hub that pretty much decides what's going to be done within a country or within a region. And then there is this idea that the hub will basically dictate most of the work that is being done by the spokes. But as we are trying all of these models, we're realizing that really spokes can be only ever as good as the hub. And in a very bureaucratic, in a very hierarchical society, you can imagine this not working very well, because somewhere, some spokes are going to lose independence, freedom, and perhaps the motivation to work more. Opposite to the hub and spoke model is a point-to-point model, where there are all of these spokes. Sometimes they're collaborating, sometimes not, but they are on their own. And I think that's not a bad model, but there are some dangers to that model, because there is no monitoring, no evaluation, etc. So what we want, basically, what we are now discussing amongst us is perhaps a model which is an empowering spoke model, where there are all of these spokes. There isn't a hub really, but there's some kind of a monitoring body, some kind of an evaluation body, where there is perhaps a rubric for grading these labs and ensuring that they are producing good quality data, and also facilitating collaboration between the spokes. With that, I'm going to end right here. Thank you so much for again inviting me and listening to me for so long. We have been extremely lucky. We are a group of 350 people in Bangladesh, and we have amazing, collaborators across the world who support us all through this work. Thank you.
We're just open for Q&A now. So if the people on Zoom can put any questions in the Q&A function, I think the chat has been disabled. And then if Etob, maybe if you come to the podium to answer questions, and we've also got a mobile mic. So if there's anyone with questions from the audience, just put up your hand, and we've got someone, Matt, I think, yes, who will give the mic. Otherwise, and then Claire will call out any, we can share, I think this one's working too, Etob. We can share the podium. So anyone have any questions? Oh, great. Yinbun, thank you.
Yeah, thank you, colleague from Singapore, right? Yeah, for the question. Yes, you mentioned about the malaria. We have a program now also to prevent the malaria from mother to the child. And then we have, especially in the Papua Islands, there are intervention given preventive with anti-malaria in the pregnancy. And a lot of intervention going on. Indonesia, we are looking forward also for the vaccine for malaria, so that we can implement it also in a very high endemic area in Indonesia. But still now, we're looking at the evidence data for the vaccine. In terms of rotavirus vaccine, we know that 60% of our hospitalized under 5 children, based on our surveillance due to rotavirus in the acute area. And for our vaccine that we develop now, based on our phase 2B study that we will implement it in the neonate. So it's immediately after the baby born between 0 to 5 days of age. According to our data, for the early neonate vaccination, such as polio vaccine, the coverage is very high because mostly the delivery is in the hospital, in the primary health centers, or in the midwife clinics. So before they discharge from the healthcare providers, the oral polio vaccine is being given orally immediately. So therefore, we use this rotavirus vaccine in our neonates. We hope that we're gonna have similar proxy of the coverage. So then we continue for the second dose. Also in the schedule of the DPT1, and it's also very high coverage. So we hope this gonna be really good because we implement it at the same time with our EP, and we're going to see the impact of this vaccine in the future. So I hope that's answer your question.
I'm also wondering, Yinbun, thank you for that, whether you were alluding to the fact that if malaria is taken away, do these other diseases get worse? Is that also what you were referring to?
So the question is, are there enough data about the long-term impact of rotavirus vaccine? So after
Rotavirus vaccine.
Trials is usually a 2 or 3 year situation.
Mm.
And after that 2 or 3 years, is there a reduction or increase in rotavirus infection incidence as compared to the never vaccinated? Because I find it I don't know anything about rotavirus, but in malaria vaccination, it has always been a concern about this kind of long-term, about a short-term success and becoming long-term failure. And I wonder whether there's a similar concern with rotavirus vaccine.
Yeah, I think in the data that we evidence from some other countries, we don't see any outbreak of the other rotavirus disease after this implementation. But what I know from other countries, there are specific genotype is come up that's a different, and normally maybe in the surveillance never found as a very high number, but in the few countries there are a specific genotype that is more common now than the previous one. But according to the data, that's not have any the outbreak data that show due to of this new genotype. Yeah.
Yeah, and I think unlike some other vaccines too, just to add, it's not a sterilizing vaccine, so it prevents severe disease. So you get vaccinated and you get protected, but you can still get infected, and that still, boosts the immune system, and so there's not that shift, as Itoba says, to other age groups or things observed, and the vaccine's been in many countries for at least 15 years now, I think too. So thankfully, no,
Yeah, I think it's been almost more than 120 countries implement the rotavirus vaccine. Yeah.
Any other questions? Just pop your hand up, and if you could introduce yourself too, who you are and where you're from, that'd be great. Thank you. And I'll repeat the question. Oh no, we've got a microphone, so that's
Hi,
great.
can you hear me? I'm Ana Ong Lim. I'm from the Philippines. And I was really very fascinated by the very sustainable approach that you were able to present. So over the past decades, where you've been able to build capacity for the RV program and for the genomics program in Bangladesh. I was just wondering, you talk about this from the perspective of your organizations. What is the role of your MOH? And I'm thinking about this from the perspective of my organization in the university as well. And considering that we are always aiming for sustainability, we really have to bring government into this and have them understand that aside from fighting the fires that are happening every day in public health, they need to be able to invest in developing a longer term approach so that we move towards prevention and not just always trying to address the crisis.
Yeah. Yeah. In terms of the sustainability, yeah, that I learned also from my senior, because this is, I also the young generation that estafette all these continuous working between this institution. What I learned is that the capacity is that maybe not the evidence or something not could not be found here, such as the big cases, the other type of virus, etc. So I think this gonna be kind of tricking of the information, of trick the scientists, especially in Australia, to find out the other cases. And Australia itself, it's maybe in the border of many countries. So I think the safety of the population in Australia also, I think it depends on the countries in the region, because there are travelers from Australia take a holiday to Indonesia, and then also other countries to come to here. I mean, this kind of issue that might also important for the country. So in terms of the sustainability in how the institution here, of course, this also the global work. A lot of, I think, as I mentioned, high income country receive the global funding, and they trust a lot of institution, academic institution in Australia to receive this funding, so that we, based on that, the sustainability of the relation between this the country. In terms of the rotavirus development, I think there are also some benefits from the countries on developing this vaccine with Indonesia and also Australia. And we hope this vaccine also will be useful future for the other countries. So again, the supply vaccines are still very challenging as well, so that developing this vaccine is benefit for the both countries. Yeah.
Thank you, Etop. And Dr. Sanjuju, you might like to add comment too. Thank you.
Yeah, thanks for that very, very important comment. At the end of the day, what we are trying are models, and we are a very small organization within the countries. That's very true. And we also think about constantly, how do we make it more sustainable? I think it's a lot about relationship building. It's something that I know I am appreciating more and more, right? As we were just hearing, as young scientists, early career scientists, it's difficult for us also to figure out what is the right way to do it. And we are constantly learning from other advocates. But something that is very important is to maintain good relationship for the very beginning. When we started building agreements with universities, we were not only working with private universities, we were working with public universities too. And that automatically, is a buy-in from the government. Another thing that's important is communication. Does the government know what we're doing? Do the policymakers know what we're doing? Are they aware? Do they realize the impact? And I think as as scientists, we're horrible communicators. We need to have dedicated people within the team who communicate the work, who understand how to communicate the work we do, the impact this might or might not have. So now we are realizing, and we actually have specific science communicators within the team. Ministry of Health is very important, definitely, but I think that's not the only ministry we should be working with. When we think about, these programs and building capacity, especially, building capacity on training and genomics, microbiology, etc., it's also important to collaborate with Ministry of Education, especially when we are working with universities, for example. So that's where we are investing in right now. How do we build that relationship? How do we work with the minister directly, let's say? Also, another ministry that has played important roles in the work that we are doing and, supporting us is the ICT ministry. The Information Communications and Technology Ministry has been very supportive. And I think that ministry in Bangladesh might be the one who will take some of the models forward and share it more widely within the country. But again, we are trying things out. We don't know what's gonna succeed, what's gonna fail, but hopefully we can continue these conversations and all of us here can learn from each other. Thank you.
Fantastic, thank you. We've got time for more questions. I think Sam.
Thanks.
just
Sam
in-
Manor here. I'm a postdoc from MCRI. I had a question for Sanjiti. I was wondering if you could comment on your experience in implementing genomic methods for serotyping in Bangladesh, because, I was wondering about, your 1090 rule and, serotyping methods or genomic methods for serotyping have been, based on data from high income settings. So I just wonder how that performs in Bangladesh, if you could kind of comment on your experience with that.
Yeah, thank you. Thank you for this question. So we are just starting our work on pneumococcus. I know very, very little about pneumococcus, and I get into a lot of trouble for that, like I am going to probably get into here. But as a rule that we have in our organization is you only store isolates if there is linked clinical data, number one. Otherwise, they do not get stored, do not get sequenced. Number two is there is good phenotypic data for the isolates. So already before the isolates are even being stored, we have phenotypic data using Kellogg reaction on what serotypes we are storing of pneumococcus. And if they're culture negative, then they go through PCR. And we also ensure for the culture negative ones, we have serotyping data. Right now, we're focusing on whole genome sequencing, on not really metagenomics to look at culture negative serotypes. The kind of work we are doing so far with pneumococcus, the kind of bioinformatics analysis we're doing so far, we're actually picking serotypes. For example, 19A, we introduced PCV10, and that does not include 19A. And we have 19A burden, but not in invasive cases, only in keratosis media. So we are trying to track how has 19A changed or not changed over the years, and why has 19A not become an invasive form. We also are trying to answer questions about serotype 1. We have seen no change in serotype 1, and why have we not seen any change? Then serotype 2, very predominant, the predominant serotype for meningitis cases in Bangladesh, and again, following that specific serotype. As for other serotypes, you are very right that most of the data have come from the global north, but I think an advantage that we have, again, this is organization specific, is we have been doing pneumococcal work for many, many years, carefully trying to do phenotypic analysis on what the serotypes are, and we are realizing that the diversity of serotypes is very high. We have more than 50 serotypes that cause diseases, and we are systematically now sequencing them and going through the data and learning more. And for non-serotypable ones, non-groupable ones, we are also going to sequence them and try to learn more about that too, but that's coming in the future. I hope I was able to answer your question.
Yeah,
Thanks so
great.
much,
Thank you.
Sanjiti. And we might just finish with the last question, and for ETOB so excellent presentations. Really enjoyed the clear instruction to high-income country academic institutions as to how they should partner with low middle-income country institutions. Do you have any guidance for governments like Australia? How can governments and multilaterals, development partners support this process? Thanks.
Yeah, thank you, Andrew, for the question. This is a very great question because a lot of countries in the region have the same issue related to the global health, especially in children. So I think that focus and prioritizing on what the need in the local and what the in common problem. And then Australia have a lot of infrastructure as well and collaboration in this region with the goal, I think achievement goal and very clear goal from the collaboration and then work together with the institution in the region and especially also the government to recognize this collaboration and also to recognize the evidence that develop, and then ensure also in the future this evidence actually be used by the local government for the decision making. I think this very important because with the clear and then work together, this could be a goal. That's what I learned also from vaccine. Yeah.
Fabulous. And highlighting how important, partnership and ownership and communication and respect and all of those things. And absolutely. So thank you. Fantastic session. Thank you very much, Dr. ETOB, and also Dr. Senjutu. Really fantastic presentations. We have morning tea now. We'll break for 15 minutes.